Hey, it's Adam Sewell, MD, and welcome to section 3.6 of the Microplastics Toxicity Training. In this final section of Module 3, we'll tackle a crucial and practical topic: how to understand and manage microplastic burden in your patients, what challenges exist in measuring it, and what happens when patients begin the process of detoxification or exposure reduction. We'll walk through a working model of how microplastics accumulate in human physiology, the current evidence on their elimination, or lack thereof, and what kind of symptom resolution we can reasonably expect as exposure is reduced. This is where theory meets practice. Part 1. Understanding microplastic burden in human physiology. Let's begin by defining what we mean by microplastic burden. This term refers to the total mass and distribution of microplastic particles and associated chemical plasticizers present in the body at any given time. And while we currently lack FDA-approved tests to measure microplastic load directly, we can build a clinical model to estimate burden based on exposure history, symptoms, and supporting labs. The model includes 4 compartments. Compartment A, GI tract lumen, active exposure. Most particles from ingestion reside here initially. Their transit time and interaction with mucosal immune cells define short-term exposure risks. Compartment B, circulatory system, transient phase. Particles and chemical residues that cross the intestinal barrier or enter via inhalation circulate briefly before tissue deposition. Compartment C, tissue reservoirs, intermediate to long-term storage. Fatty tissue, liver, kidneys, lungs, lymph nodes, placenta, and potentially the brain act as storage sites. Particles may persist here for months or longer. Compartment D, intracellular and cellular matrix binding sites, chronic entrapment. Nanoplastics can enter cells via endocytosis and become sequestered in lysosomes or bound to cytoskeletal proteins. This compartment has the longest estimated retention time. Part 2. Routes of clearance, what the body can and can't do. The human body lacks a dedicated pathway to break down synthetic polymers. However, there are limited size-dependent pathways for elimination. GI excretion. Larger particles that don't cross the gut barrier are passed in feces. Fiber, bile flow, and mucin production assist in particle entrapment and removal. Biliary excretion. Some plasticizers and lipophilic compounds can be conjugated in the liver and secreted into bile. Renal clearance. Only nanoplastics. Less than 20 nanometers may pass through the glomerular filtration barrier. Most are too large. Sweat glands. Several studies, including the human excretion of bisphenol A, blood, urine, and sweat, BUS, studied by Genuis et al., 2012, in the Journal of Environmental and Public Health, show that BPA and phthalate metabolites can be eliminated through induced sweating methods like sauna therapy, macrophage transport, and mucociliary clearance. Inhaled particles may be expectorated if not deeply embedded. Unfortunately, most microplastics that cross into tissue compartments are resistant to breakdown and poorly mobilized. Part 3. Estimated washout modules, a theoretical clinical model. To give clinicians a working model, we've outlined a theoretical timeline of washout modules, phases during which different compartments may begin to unload microplastic burden after exposure reduction. Module 1, timeline, days 0 to 14. Targeted compartment, GI tract lumen. Expected symptom response, GI relief, reduced bloating, decreased urgency. Module 2, timeline, weeks 2 to 8, targeted compartment, circulating load and bile excretion. Expected symptom response, improved energy, less fog, normalized appetite. Module 3, timeline, weeks 8 to 24, targeted compartment, fat, liver, lymph, skin sweat. Expected symptom response, hormonal balance, mood stabilization, weight loss. Module 4, timeline, months 6 to 18, targeted compartment, intracellular retention, central nervous system. Expected symptom response, neurological healing, improved focus, memory. This model is not absolute, but it aligns with case observations and research timelines from detoxification studies involving BPA and phthalate metabolites. Part 4. What happens when patients cut exposure? So what can you expect when a patient starts reducing microplastic exposure? Week 1 to 2, initial GI reset. Patients often report less bloating, improved stool regularity, and early reduction in headaches or fatigue. This may be due to reduced mucosal irritation and lower systemic LPS leakage. Week 3 to 6, improved liver function and circulation. If bile flow is optimized through choleretic herbs, phosphatidylcholine, or sauna use, some chemical residues like phthalates and BPA may begin to clear. Energy levels often improve. Patients may report better sleep and more stable mood. Week 6 to 12, hormonal stabilization phase. As plasticizer interference diminishes, hormone panels may show lower sex hormone binding globulin, better estradiol, testosterone ratios, and normalized cortisol rhythms. Fertility patients may see better ovulation and libido return. Months 3 to 6, neurological resolution begins. Patients with brain fog, sensory sensitivity, or mood instability often report major gains here. Antioxidant support, like glutathione or N-acetylcysteine, may accelerate this phase. In models, brain-derived neurotrophic factor and synaptic plasticity markers begin to normalize at this stage. Part 5. How to track progress in the clinic. Until we have direct microplastic burden assays for clinical use, here are some proxies. Serial symptom surveys. Track GI, mood, cognition, and hormonal symptoms weekly or monthly. Repeat hormone panels. Look for estradiol, testosterone, dehydroepiandrosterone, cortisol normalization. Liver function tests. Monitor alanine aminotransferase, aspartate aminotransferase, bilirubin, particularly during bile-boosting protocols. Oxidative stress labs. Measure gamma-glutamyl transferase, 8-hydroxy-2-deoxyguanosine, or lipid peroxides when available. Urinary BPA phthalate panels. Available through some specialty labs. Track metabolite drop over time. And always pair clinical data with lifestyle tracking. Are they using glass containers? Avoiding bottled water? Using clean personal care products? These behavioral changes are the most powerful lever for long-term reduction. To summarize, microplastic burden in humans is real, chronic, and complex. It involves multiple compartments from GI transit to long-term tissue entrapment. While clearance is possible, it's slow, compartmentalized, and requires consistent effort from both physician and patient. But here's the good news. When patients reduce their exposure, they can feel better. GI, mood, hormonal, and cognitive symptoms often improve in sequence, and now you have a framework to help guide and support them through that process. This concludes Module 3 of the Microplastics Toxicity Training. In Module 4, we'll shift focus to diagnostics, looking at which lab markers, imaging, and symptom clusters can help identify patients with suspected microplastic toxicity. Thank you for committing to this training. You are now part of the movement to bring environmental medicine into daily clinical practice. Let's continue forward, together.